Regarding fluid therapy in ICU, I'm trying to present it in an innovative infographic way in less than 8 minutes. Coming to fluid therapy in ICU, there is fluid is considered as nowadays as a drug, and consider remember 4 days. Fluid is a drug. There is a dose, there is a duration, and there is a de-escalation. Coming to fluid therapy, the process of administering fluids to maintain the normal fluid balance is considered to be as a fluid therapy. Balanced salt solutions and colloids, balanced salt solution have a composition similar to plasma. Colloid solutions have a macromolecules. There is an importance of stressing fluid stewardships, just like an antimicrobial stewardship, where there is a series of coordinated interventions to select optimal fluid dose, right fluid, right duration. As of now, there are four indications of fluids: resuscitation, maintenance, replacement, and nutrition. These are all basic components of fluid responsiveness where there is an increase in stroke volume and cardiac output after administration of fluid. Fluid bolus, giving a 4 to 6 ml per kg or 10 to 20 minutes is considered as a fluid bolus. There is a fluid challenge, you give the 4 ml per kg along with hemodynamic monitoring. Mini fluid challenge, 1 ml per kg or 1 to 5 minutes. And regarding fluid creep, unintentional fluid overload caused by either nutrition or your drug administration. Fluid accumulation is considered as a syndrome nowadays, and global increased permeability syndrome, where multi organs are affected because of fluid accumulation. Coming to basic physiology, there is venous return is equals to cardiac output. There is a stressed volume, unstressed volume concept, where 30% is stressed volume, and there is an equilibrium point between venous return and cardiac output. Whenever there is a fluid bolus, there is an increase in stress volume with a shift of venous return towards right. In a septic shock, consider some Mr. Sharma with clinical evidence of septic shock. You give a fluid. There are three possible scenarios. You get a desirable effect where there is a minimal increase in right atrial pressure, increase in venous rate and cardiac output. Scenario two, there is a vasopressic state where stress volume will not increase and there is a non-response to the fluid bolus. Undesirable effect, there is a chance of fluid congestion accumulation. So these are all basic physiological principles. Coming to normal saline, a comprehensive review, there are various studies comparing balanced saline solutions compared with the normal saline, split study, salted study, smart study, basics plus meta-analysis. There is no significant difference in mortality comparing normal saline and balanced saline. But coming to normal saline, it is not so normal saline because there are many adverse effects of large volume saline administration, metabolic, there is an acid pH abnormality, sodium overload, chloride overload, chloride acidosis, endothelial damage, kidney leading to acute kidney injuries, cardiovascular, increased vasopressor needs, sometimes gastric paralysis, ileus, manifold. Coming to albumin, surveying sepsis guidelines have suggested of albumin for fluid resuscitation in those who have already received large volumes of fluid. Chinese society have recommended when there is a hemodynamic instability, considered as a signs of apparent chemical capillary leakage, frequent fluctuations map less than 65 in spite of fluid bolus. Safe study, always study, raspberry. No randomized control trial has evaluated the optimal timing of albumin administration. Type study has said 20% has lesser fluid accumulation compared to 4%. In AKA, albumin with telepressin is an effective to an extent, SBP to an extent hypoalbuminemia, there is a mixed results on survival benefits. In ARDS treatment, PAL strategy P 20% albumin furosemide treatment in ARDS showed improved outcome with lesser native fluid balance. But consider at the same time, there are myths. Albumin does not always lead to leaks, does not always cause edema. Albumin is sometimes effective in preventing acute kidney injury in certain specific settings. Albumin improves effects of diuretics, but only temporarily. Many more myths continue. At the same time, there is cost effect. There is sometimes albumin leakage. There is traumatic brain injury. It is not preferred. Okay. Coming to septic shock, we have already discussed. Individualized fluid dosing is being stressed nowadays. Fluid challenge, along with hemodynamic monitoring, restrictive fluid strategy, all should be measured. Coming to fluid responsiveness in right ventricular failure, there is a need for assessing fluid overload in such because of right ventricular failure. Pick up on monitoring 2 to 5 rule, monitoring pulse pressure variations, eco assessment, even advanced hemodynamic monitoring techniques are needed. Coming to left ventricular failure, fluid responsiveness is very important in such cases. Dynamic measures are important. PICO, PLR, ECO, others should be adopted. In trauma patients, polytrauma patients, early use of fluids, early use of blood products, limiting aggressive fluid resuscitation is now considered. Normal saline is preferred in traumatic brain injury, balance and salt solution, even in other patients. There are three types of responders in a polytrauma: rapid responder, transient responder, non-responder. Deresuscitation is important to prevent tissue edema, compartment syndrome. Coming to burns, first step is in management is calculating body surface area and giving of fluids 4 ml per kg. Importance is early resuscitation prevents renal failure, organ dysfunction, even death to an extent. Coming to neurocritical care, isotonic crystals are preferred, not recommended. No recommendation regarding balanced solutions. Not recommended fluids include glucose, 4% albumin, glucose containing solutions, high concentration albumin also. Fluid management of choice is normovolemia, multimodal monitoring. Coming to secondary intraabdominal hypertension, risk factors include sepsis, burns, pancreatitis, anything there is venous congestion, there is accumulation of fluid leading to multi-organ involvement because of the intra-abdominal pressure increase. This is a time for introspection. One size fits for all. It should not be followed. There is a failure to account for individual patient physiology. Reassessment of traditional markers, limitations of CVP nowadays. Emerging markers include PLR, eco-guided microcirculatory tools. Questioning the timing and duration, early goal-dated treatment, lessons learned from ARISE process and promise trials. Concept of deresuscitation is being given importance. Importance of frequent reassessment is needed. Evaluating the impact of fluid choice, crystalloids versus colloids, safety concerns with HESTA, role of albumin has been discussed. Balanced and unbalanced, there is as of now no strict recommendations. Even hydrogenic fluid overload, recognizing the hidden fluids is very important. Hidden fluids because of drug administration, nutrition, blood products, and everything. Cumulative fluid balance leads to multi-organ dysfunctions in the patients. Individualized, there is a need for individualized fluid prescriptions, tailored fluid therapy based on the patient age, morbidity, presenting conditions, disease-specific conditions, even genetic factors of handling vascular permeability. Developing personalized fluid responsiveness thresholds is important in considering all physiological parameters. Integrating multiple parameters for fluid management beyond a single parameter, move away from single parameter, take into multi parameters when taking a decision. Create an indices for fluid management. Potential for fluid management score is a need for novel fluids with enhanced therapeutics, smart fluids for specific scenarios, exploration of alternate fluid composition, nanotechnology in the future can help. AI-guided fluid management, machine learning algorithms for predictive modeling, decision supporting systems, closed loop systems may come up in the future. Continuous non-invasive monitoring of fluid status, advancement of bioimpedance technology, optical technology, integration with the existing ICU monitoring system is the need of the hour. Thank you.